is same way. Hysteroscopy is one of the common procedure performed by the gynecologist all over the world, and the incidence has increased recently because of the new procedure like IVF and infertility cases. It has a lot of advantage. By definition, hysteroscopy is a visual examination and interpretation of inside the uterus with a telescope-like device which is called as hysteroscope. And you will introduce it through the vagina, it goes through the cervix. Hysteroscopy was first done long back, and it was one of the surgeon whose name was Pantalini in 1869. You can see more than 200 years ago. And at that time he examined by the naked eye, no camera, no telescope. And this is the original photograph, original picture which was published at that time. I don't think anything was visible because of bad quality picture, but it was an idea which has clicked on. Nowadays we use in the operating room setup. This is the typical hysteroscopy setup. You have to keep one monitor, light source, light cable will be same, camera will be same, your telescope will be different. You will have 4 mm 30 telescope. That is a typical telescope. There are some smaller diameter telescopes are also available, like one is Versascope. Versascope is made by Johnson & Johnson Ethicon company. One day they will come with the Versascope to you to sell, and it is 1.8 mm diameter, so it is very good for diagnostic hysteroscopy. You can do in the operating room setting. Without any extraordinary, operating room setting can be performed. You have the different fluid for that. You can use glycine, you can use normal saline. When to use what fluid, that I will show you now. First we should understand the anatomy, that already you are aware of, that this is external os, this is internal os, this is uterine cavity, and then you have cervical canal. Now here this is the ostia. Indication, once you will start doing hysteroscopy, you can use it anytime. Sometimes the gynecologists are so fond of doing hysteroscopy that routinely they perform before any hysterectomy also. If you have to do hysterectomy, you can do one hysteroscopy before, so that in cases of malignancy and all, at least you can take the endometrial biopsy. So it's becoming an office routine setup, and you can do in the multipara very easily. What are the most important indications are evaluation of unexplained uterine bleeding in pre or post-menopausal patient, diagnosis and hysteroscopic removal of suspected submucous leiomyoma or endometrial polyp, then the location and retrieval of the lost IUCD and other any foreign body, exploration of the endocervical canal, internal cervical os and the uterine cavity in patient with repeated miscarriage, evaluation of the patient with failed first trimester elective abortion, and transcervical division of the small uterine septi. These are the most common indication of the hysteroscopy. Patient has to be sit in the lithotomy position, you will put it, and the level of the vagina should be at the level of your elbow. Should not be much down, otherwise you will have to bend. It should not be much up, otherwise you will not be able to manipulate your instrument. 2 assistants you require. One will help you to give the pump, give the instrument. One other assistant other side, he will stabilize the your speculum during holding the tenaculum, because once your hysteroscope is in your hand, you cannot hold your own. You need some help by someone. If you are doing pelvicoscopy, pelvicoscopy is a procedure in which we are combining diagnostic laparoscopy together with the hysteroscopy. If you are planning for pelvicoscopy, in those situations you should try to put the telescope before. don't put the hysteroscope first, because if you ये blue वाला light बंद कर दो, ये light जला दो. If you are doing the hysteroscopy first, then at that time uterus will become a little inverted, and you have a little fear that in those situations there may be injury of the uterus with the trocar. Heat and trial mat karo. You have to careful, because trocar can hit it. If you will put laparoscope first, then it has a lot of advantage, like you can see the trans illumination. And if you are doing the big procedure like metroplasty, septate uterus, big myoma, then in cases of any perforation also, it can help you to get the idea, and it can prevent a lot of injuries. Before doing hysteroscopy, you should do the PV examination. You should avoid any infection. If the patient has any infection of the cervical canal, or you are thinking of any fungal infection, bacterial infection, foul smelling discharge, then in those situations hysteroscopy ideally should be delayed. We should give some antibiotic first. Diagnostic hysteroscopy you can do in the office setting also, but for operative you have to do the operating room setting under anesthesia. Even if you are doing in the operating room setting, you should check for any cervical stenosis, and it is better that 2-3 hours before the procedure we should put some prostaglandin tablets. In the small gauze piece you can put mesoprost 2 tablets with the moist saline, and then there will be, especially in nulliparous, because there will be softening of the cervix, that will help you to introduce safely. You may not need to dilate it also. In multipara it is not necessary, because anyway you can introduce it much better. This is a conventional hysteroscope, that is 4 mm 30 degree telescope, and it is always better to use 30 degree. Some of the companies are making 7 degree, 15 degree, 30 degree, but 30 degree is more appreciated. There is no 0 degree hysteroscope, because you must see on the side. With the 0 degree you will see only fundus, and it will be very difficult to see the ostia. If you will try to move the entire telescope, then the problem will occur that uterus also moves together. So if you have a 30 degree, you can hold the hysteroscopic sheath and you can move the light cable. If you are moving light cable to the left, you are seeing right, and vice versa. Resectoscope is used for operative procedure. This is resectoscope. Resectoscope is the same instrument which was used by the urologist for TURP long time. There is no separate resectoscope for gynecologist. The same resectoscope which is used by urologist for the different operative procedure, for prostate, for the bladder neck surgery, they use the same by gynecologists. It has 5 components assembled together. These are the components. And what are the 5 components? I will show you tomorrow, and tomorrow you have practical of hysteroscopy also. One component is hysteroscope, another component is outer sheath, another component is inner sheath, another component is working element, and the third is electrode. What you should do first? First you will take electrode and fix it to the working element. This is electrode going to the working element. There are different type of electrodes available. Most common are loop electrode, another is Collins knife, another is roller ball, another is a straight knife, depending upon what you want to do, and we will see it also in the video of surgery. Suppose you have to take the only transcervical resection of endometrium, then you will use loop electrode. If you have to perform myomectomy, you will use loop electrode. If you have to do metroplasty and if septate uterus, then you will use a straight knife or Collins knife. If you have a polyp, then you can use Collins knife. So depending upon the requirement, different type of the loop electrode has to be used. So first you will put the electrode into the working element. After that you will put the inner sheath. This is inner sheath going. What is the function of inner sheath? Inner sheath has two functions. One function is at the tip it is made up of ceramic, and that act as a insulation. Another function is it is taking the fluid inside. So taking the fluid in is by the inner sheath, and it has a ceramic tip which doesn't allow the tip of the sheath to burn, because high temperature is there with the electrode and doesn't allow the electric current also to be transferred to the working element. So this is inner sheath. After that you have to put outer sheath. This is outer sheath. Outer sheath has the main function that it is taking the fluid out. This is fluid exit channel. And lastly you will put the telescope. And now this resectoscope is assembled. This is ready now to use, and this way you will run it. So all together you have the working element, electrode, inner sheath, outer sheath and telescope. These are the 5 things which is assembled together. There are 2 types of resectoscope. One is active, another is passive. What is the difference between the active and passive resectoscope? That I have to show you practical, which I will demonstrate you in the lab. That what is the difference in the functioning of the active and passive. There are few micro hysteroscopes are available in the market. That has our conventional hysteroscope doesn't have much magnification. It is unit magnification. Magnification depends upon the distance, and it depends upon the size of monitor. So that way magnification will be decided. So as such there is no magnification. But there are some micro hysteroscopes are available that has 20 magnification, 60 magnification and sometimes 150 magnification. Advantage of having 150 magnification is that even you can see the cytoplasm and nuclei of the cell. That is basically used by the microbiologists and some of the molecular biologists, which is for reproductive, assisted reproductive technology. They do some of the identification of the different pathology, they use it. Now distending media. Once the hysteroscope once upon a time was started, at that time the best distending media which anybody could see was the carbon dioxide. Carbon dioxide has many advantages. One of the biggest advantages is that it is 200 times more absorbable than oxygen and 20 times more absorbable than room air. So chances of embolism was less, and it is good vision also, because it will, like fluid, it will not make your telescope dirty, but it has many disadvantages. One of the biggest disadvantage of the carbon dioxide is that the pressure has to be increased 150 to 160 millimeter of mercury. During hysteroscopy, pressure has to go 150 to 180 sometime, and at that temperature there will be a lot of extravasation and intravasation. Now what is extravasation? Extravasation means if the fluid is going any third space, or if it is going into the peritoneal cavity, or if it is going in the different layers, this is extravasation. And intravasation means it is going into the vein, that is intravasation. So gas is thin, and at the end of 1 hour of the suppose hysteroscopy, entire abdomen will be full with the CO2. Patient will get shoulder tip pain. There may be some dyspnea also if the pressure is more. So this is one problem, that it is very fastly diffused to the abdominal cavity. Another problem of the CO2, it may be used for diagnostic, but it is not used for operative. Because problem is your telescope is so nearer to the polyp or endometrium that as soon as you will burn, Suppose some tissue you will burn, some tissue you will cook, your tip of the telescope will become smoked. Even in laparoscopy it is happening. But in laparoscopy at least our distance from the target of dissection is 10 centimeter. But here we are 1 centimeter or 2 centimeter. So immediately your telescope will be smoked. Another problem, if there is a bleeding, immediately it will become a clot. And that clot will not allow you to perform surgery. So due to this difficulty, the gynecologists they thought that we should use some fluid medium. And the first fluid medium which was used was dextran 70. This is high viscosity fluid. It was good that it was not escaping inside the abdomen, but the vision was not good. Then the low viscosity material like dextrose, like the normal saline, 5% or 10% dextrose it was used. Dextrose is good for operative, but normal saline you cannot use for operative with the monopolar, because conventional hysteroscopes are monopolar. So if you are putting your monopolar current, all the current will be taken by normal saline, and the amount of intensity of the current which you really need to the tissue to dissect, it will be very less, and you will be no effect. Your effect of the current will be minimized, and there is a potential risk of dispersion of the current to the other tissue also. So that's why normal saline can only be reserved for diagnostic hysteroscopy. Normal saline cannot be used for operative. Dextrose can be used, but the problem of the dextrose is two. One problem, dextrose doesn't stop clotting. Clot of the blood will occur even in the dextrose. Another problem is sometimes the amount of dextrose which has been introduced into the abdomen through the fimbria, and if it is collected into the cul-de-sac, it may be a potential risk for the PID, because carbohydrate a good culture medium for the bacteria to grow, and potential risk is there. Although if you are combining with the laparoscopy you can suck it out, but if you are doing only hysteroscopy then it is a concern. So ultimately you have the glycine for the operative and the normal saline for diagnostic. Glycine was discovered as a fantastic media for the operative hysteroscopy. Why? One of the biggest property of the glycine is it doesn't allow the blood to coagulate. It keeps the intrauterine bleeding into the liquid form. So once the clot is not formed, if the blood is in the liquid, then immediately that blood can come out with the channel of your resectoscope. So it will not block it. If the blood is coming with the fluid, it is coming out, it is draining out, because we have the channel input and output, so it is washed out. And if it is clearly washed out, then we can see the bleeder point distinctly and we can coagulate it. Another good property of glycine is it's a natural amino acid. So generally it doesn't react with the human body, because in our blood already glycine is present. Another good point, it inhibits ionization. It inhibits the ionization of the fluid. So current will not disperse to the any area. But there is a one drawback, that it creates hyponatremia. And hyponatremia means through the loop of the Henle of the kidney, it will push the sodium out, and the sodium will decrease in our serum. And what will happen? Now my question is that what is the first sign of hyponatremia? How you will know that patient has the hyponatremia? Confusion. Yes. First is confusion. Then comes delirium. Then comes the stuporose, and then comes unconscious. And then there may be organ failure, heart and respiratory problem. So 2-3 points has to be kept in mind, that how to prevent this hyponatremia. And if happens, how to diagnose. And third point is how to treat. Prevention of the hyponatremia, again 3 points has to be kept in mind. First, time of surgery. It should not be prolonged for more than 1 hour in one go. Suppose you have a very big myoma, submucous myoma, and you could not do immediately, then never mind, do it next day. But don't try to continue for a long session at one time. Next day means after 2 weeks, 3 weeks, not very next day. Another, pressure. Pressure, if it is more, there will be more intravasation. So pressure you should limit to 150 to 180. If pressure is more, there will be more intravasation. And third is, input and output of the fluid at the end of the procedure must be, fluid deficit should be calculated. Like suppose you have used 3 liter glycine and outside only 500 ml came, then where this extra 2.5 liter gone? That is, you have pushed all into somewhere, and then there is a concern. So if you will take care of input and output, amount of glycine is not a problem. You can use 20 liter glycine also. As long as glycine is going into the cavity and draining out, it doesn't create any problem. But suppose going in and coming out less, then it is a problem. Isn't it? So that's why generally you should have the good fluid insufflator, that is known as endomet. Here you are seeing that we are using Medex pump, but you can use the fluid insufflator for hysteroscopy. Storage is making, and it has a calculation for the fluid input and fluid output, how much you have used. It will tell you at the end of surgery. But that also is not very useful. Do you know why? Because it can never calculate the amount of fluid which has leaked from the cervix, dribbling through the vagina, going to the floor. So that you have to mop out all and collect into one bucket and then measure it, that how much it is. This is the rule. But generally we don't follow it. And we calculate roughly that much is the deficit. So this is how to prevent. Now question is how to diagnose. For diagnosis, after procedure, you should try to avoid giving any of the sedative to the patient. Narcotic analgesics can be given for pain, but don't give Contramol or Fortwin or Pethidine, because you will confuse between the real confusion of the patient and the effect of the medicine. So your nurse should be given this instruction. They should keep talking with the patient at least for few hours after the procedure, because sometimes hyponatremia reflect the symptom little delayed, and in those situations you will be in trouble. Serum electrolyte also has to be done in case of any doubt. And now next question, how to treat. If it happened, then hypertonic saline has to be given, not the normal saline. What is the normal saline concentration? 0.9%. So you will give 3% saline. 3% saline will not be called as normal saline. Normal means 0.9 and 3% means hypertonic. So hypertonic saline can be given, and that can relieve the problem. Suppose you will immediately diagnose it, you can immediately treat it without any consequences. But sometime our diagnosis is delayed. Sometime we come to know after, once the patient has already cerebral edema and once the patient has lost the consciousness. In those situations, what we should do? We should put the mannitol to the patient, and ICU shifting is required. So better is we should not try to get into that situation. Water intoxication is another. Water intoxication, why it happens that instead of glycine, sometimes some people they use sterile water, and sterile water, distilled water. because normal saline and the plain water after boiling you cannot use, because in any water some salt is always there, and once the salt is there it will take the current. So if the glycine is not available, then they use distilled water, and that creates water intoxication because it is hypotonic, and hypotonic can create water intoxication. Sometimes dextrose also creates water intoxication. So that has to be kept in mind. Now how to do the procedure? First thing, you should put a sound. Take a tenaculum, hold the cervix, and you will put a sound. So that, but before that, if the patient is nulliparous, it is a good idea to inject little bit xylocaine or lignocaine all around the cervix. Do you know what is the advantage? That it will create cervical block, and the chances of vasovagal attack can be minimized. There will be less chances of vasovagal shock. So then you will put the sound, dilate it. Now in the nullipara, you may little dilatation sometime, but not always. If you have a good quality, a small diameter hysteroscope, it goes with the fluid itself. But sometimes if the narrow constricted cervix, then gently you may have to dilate. And in those situations, over dilatation should be avoided, because you will not get a good distension. All the fluid keep on returning from the same path. Now you will attach it, and then you will introduce the hysteroscope. Once you will introduce the hysteroscope, in the beginning nothing will be visible, and you may have to wait for a couple of minutes, and then you will start the. Do you know how the cervix open? Cervix doesn't open its own. First fluid will go to the uterus, and once the uterus is distended, then the cervical canal will open. First internal os, then cervical canal. So we cannot expect that just after irrigating the fluid, immediately everything will be visible. You need to spend some time, and after that you will introduce your hysteroscope inside. And this is fundus. Fundus will be visible. In hysteroscopy, texture gradient, this is looking like polyp. And here if you will go a little beyond, you can see the ostia. Texture gradient is very important. If the texture is bright in hysteroscopy, that means it is nearer. If texture is dark, that means it is deeper. Because we don't have the three-dimensional view, and the depth perception, you have tubular vision, monocular tubular vision, because instrument is going into the same channel where the vision axis and the instrument axis is parallel to each other. So texture gradient helps you a lot, and we should learn the depth with the different depth cue, like texture gradient, relative size, motion parallax, linear parallax, and shadow. So here this is brighter. This is brighter means it is elevated. Here this is dark means it is deeper. And this way you can see that both the ostia can be visualized. If you have to see right ostia, the light cable should be pulled to the left. If you have to see the left ostia, light cable has to be pulled to the right contralateral side, and then you can see it better. And then slowly you will withdraw the hysteroscope once the final diagnosis will be sufficiently done. These are the endometrial flakes. Sometimes the beginners, they confuse the endometrial flakes with the polyps, or a blood clot with the polyps. So if you go very nearer, your magnification is huge, and that's why we confuse. So endometrial flakes are looking like a flag. It moves like a flag, and it moves like a flag if you will go a little away, and that way it can be discriminated. So this is, you can see it is little brighter. Brighter means the fundus was little towards you. It was little bit looking like a arcuate type of uterus, and that way you can diagnose it. Now again we are in the, this is internal os, and you are in the cervical canal. So that way initial diagnostic hysteroscopy can be performed. After that you will start performing the final surgery if the surgery is required, and if you have a consent from the patient, you can perform the operative procedure also. I am going to show you some of the pathology, so that during the common pathology, so that during performing the diagnostic hysteroscopy you can identify these problems. Like this is how it looks like endometrial polyp. This is the endometrial polyp. This is atypical adenomatous endometrial hyperplasia. This is endometrial carcinoma. Cauliflower like growths are there, but for definitive diagnosis you have to use biopsy. Just like in the endoscopy, today for surgeon I have shown you how to take the biopsy. You have the biopsy forceps. Same type of biopsy forceps is used in operative hysteroscopy, where you have the flexible biopsy forceps. So you can go, you can take the biopsy and come out. Sometimes you have the myoma. Here you can see two myomas are there. This is one myoma and this is another myoma. These myomas are used, and if you want, you can, with the hysteroscopy, you can do resection of the leiomyoma. Septate uterus. This is submucous myoma, and this is loop electrode. Tomorrow I will put you to this practical of using the loop electrode. You can use and you can take it out. Sometimes you have endometrial polyp that is used to resect at the base. Sometimes you have the forgotten IUCD. In those situations, again you have to go catch it and pull it out. Sometimes Asherman syndrome, where extensive intrauterine adhesion can be found, and in those situations sometimes it is so dense that you have to do increase the pressure sometime to 300 millimeter of mercury. But before going to that high pressure, you should put some atropine to the patient to prevent the vasovagal shock. One extra ampoule of atropine. Atropine should be given anyway before any procedure. Even if you are doing a hydrocele, you are giving atropine. Even in the ketamine you inject, you give atropine. Why? To prevent any vasovagal shock. And here one extra ampoule can be given, and then you can increase the pressure. Now you can see all is white color. All is not the any grass of a wool type color of endometrium is lost. No endometrium here. In those situations, sometimes you can increase the pressure to 300 millimeter of mercury, so that you can break those dense adhesion. And sometimes Collins knife or a straight knife is used to cut those adhesions out, and that way we can identify it. So this way Asherman syndrome and the other procedure can be found. Now sometimes you have a dense intrauterine adhesion, like in this case you can see that there is a dense, this is the uterine cavity, and dense sometimes intrauterine adhesion looks like a septate uterus, but MRI is a very good investigation for that, and that can discriminate between these two. Here you can see this is a dense adhesion looking like a septate uterus, but it's actually adhesion. Now in the uterus laparoscopy was good, ovary was good, and in the septate uterus, do you know what is the one of the biggest is you have a whitish fibrous band in the middle, but in this you cannot see any band. That means it is a normal uterus, but inside is not a septate. Septate uterus is a congenital problem that starts from the birth, but here it happens later, and in those situations you can do the metroplasty. How to do metroplasty? You will just go and you can burn this intrauterine adhesion with a straight knife. You can cut it. Collins knife also can be used. A straight knife can cut in the middle. Collins knife is just like your L hook, which we are using in laparoscopy. Same way it looks like. So here we can see this is the intrauterine adhesion, and then with the Collins knife which will be cut. In the middle only you need to cut. It is not necessary to cut on the top, on the bottom, because even in the cases of adhesion, just in the middle you will split, and then you must put one IUCD to prevent re-adhesion. The role of corticosteroid is controversial. Some gynecologists they put some corticosteroid, another group they say it is no benefit. you are unnecessarily increasing the chances of infection. Use of hormone is necessary. That is estrogen you will give and try to regenerate the endometrium again. So this is a straight knife here, and this straight knife is cutting the adhesion. Very careful. Again, darker. Darker means deeper, and brighter means nearer. This is known as texture gradient, and this texture gradient can help us to do the difference. Now again I will show you many situations. If you will do laparoscopy together with the hysteroscopy, together with the falloposcopy, then you can rule out almost all the tubal cause of infertility. So here, this is a guide wire, and this is laparoscopy. And this laparoscopy, you can see this is tube, and this guide wire is going, and it will be taken out through the fimbria. Slowly it goes there, and through the fimbria here we can see it coming out. Just it is about to come out to the fimbrial end. Here, this is fimbria, and this is fluid is escaping now. So this is very good. Now you have to do sometime falloposcopy. Now question is, why to do falloposcopy? If already it was open, nice fluid was going. Do you know, in European country, females also smoke, not only male. So the problem is, their cilia will be lost. And cilia, if it is not functioning, if it is absent, only lead pipe like open tube cannot give you baby. It is a cause of infertility, because it needs to propagate the egg towards the tube, and it needs to bring the sperm also there with the ciliary movement. So loss of cilia is one of the cause of infertility for heavy smoker female. In those situations, falloposcopy is very good. It can rule out. Here you can see, this is the light, this is ovary, this is ovarian ligament, and this is the light coming. From where this light is coming? This is falloposcope, and it has find out. So if you need 3 cameras. One is laparoscope, one is hysteroscope, this is hysteroscopic view, and one is falloposcope. You have 3 monitors. This is laparoscopy, this is hysteroscopy, this is falloposcope. Tube within tube within tube means you are going into deeper cavity. But sometime with the one camera also you can do. Do you know how? First you will put hysteroscope and then pass it. Then that same CCD you connect to the laparoscope and see that it is in, and then you do the same CCD to falloposcope. So if you don't have those many setup, then even with the same CCD you can do it, but you will not enjoy it. So it is better to have 3. This is endometrial carcinoma. Sometimes hysteroscopic correlations are very useful. Like here, this is septate uterus, and this is looking like a bicornuate uterus, and this is septate uterus. So laparoscopy has differentiated from septate from the bicornuate. So this is MRI. This MRI is showing like it is a subserous myoma. This was a subserous myoma which was removed by laparoscopy, and multiple layer suture was applied, but there was one hysteroscopic myoma. Now question is, if you have the submucous myoma and intramural myoma, then which one you will remove first? Submucous. Do you know why? Because if you will do intramural myoma, the cavity can rupture with the fluid. So first you remove the hysteroscopic myoma out, and then you do laparoscopy, isn't it? If you will take the intramural myoma out, already you are weakening the uterine wall, and then there is a fair chance during hysteroscopy it will open. So these are a small precaution and hysteroscopic. So here hysteroscopy was done, then laparoscopy was done, and then it was nicely sutured. This is one ultrasound. This is ultrasound, and here this is the myoma. This is HSG, histosalpingogram, for the same myoma, and this is hysteroscopy for same myoma. This is a ultrasound HSG for the endometrial carcinoma. You can see irregular wall. This is hysteroscopy for endometrial carcinoma. Here is a cauliflower like growth, and this is the hysterectomy done, and this is the resected uterus to see the same pathology. So many a time we have to correlate one investigation to another. Operative hysteroscopy is now emerging as one of the important tool, and in many situations it can replace the need of the hysterectomy. If you are good in hysteroscopy, many times, like for DUB, for the myoma, for the different type of other problems, you can take care and there may not be need of hysterectomy. But whenever you are doing hysteroscopy, these layers have to be kept in mind. First layer, do you know what is there? This is known as functional endometrium. This is looking like a carpet of wool, like wool, very soft. After that comes the internal longitudinal layer, and this is the point looking like a rectus sheath, and then comes the outer circular layer, and then you will enter to the venous plexus, and then you will perforate. So whenever you see the whitish sheath like a structure, that means it is limit now, you should stop. You should not go beyond. But sometimes it doesn't work, because the things are like that you cannot help. It doesn't go. Because if it is a complete ascerment, a complete fibrotic, basal layer is also damaged, functional endometrium is no more, then the layers are lost. But in normal uterus, this is the layer which we have to remember. Functional endometrium, then the external longitudinal layer, then the internal, this is internal, and then external circular layer, and then venous plexus. This is how the normal endometrium looks like. TCR is a good procedure, that is transcervical resection of endometrium. Once upon a time, it was one of the very ideal procedure for DUB. But now, due to the newer quality of like the therma choice, balloon ablation, marina, and this and that, now the incidence is decreased. But still many gynecologists who are fond of doing the TCRE, they are habituated with that. And then slowly you can cut the functional endometrium out. But you should take care that once you reach to the whitish sheath like a structure, then you should not go, you should go to the, move to the other direction. Because once you will go to the external circular layer, then bleeding starts. So that how you can discriminate with the texture. That texture is like rectus sheath, and then we should try to stop it. Don't go beyond that. So this is one of the popular procedure which can be performed. Another popular procedure is myoma. We know there are three types of myoma. One is subserous, another is intramural, and third is submucous. And in submucous you have three grade, just like subserous. Here also three grade. Grade 0, grade 1, grade 2. This is grade 0. Grade 0. Grade 0 myoma is predominantly pedunculated. Another is you have grade 1. In that more than 50% in the cavity and less than 50% in the muscle. Another is grade 2. That is predominantly in the muscle, less than 50% in the cavity. Grade 0 is the best for hysteroscopic, gold standard you can say. Grade 1 you have to be good. Grade 2 is very difficult to perform because you have to dig the myoma out from the muscle, and that should never be attempted. So what we should do? We should do in multiple sitting. Like you should do the de-roofing of the myoma, whatever is in the cavity portion, that we should cut in one sitting. and send the patient, call again after 3 or 6 weeks. So by the time muscle will push rest of the myoma again to the cavity, and then the next time it will be safer, and then it will degenerate and comes out. So these are the different grades of the submucous myoma which you have to decide. Myoma must be differentiated from the adenomyosis, because sometime due to our wrong diagnosis you are in trouble. So this should not happen. Now when you are doing the diagnosis, then diagnostic hysteroscopic sheath has to be used. This is the myoma, and here this is dark, means deeper. So this is grade 0. This is good myoma to perform. It is easy. There is less chance of perforation, because already it is inside, predominantly in the cavity. And then you can perform. How to perform? You will take the electrode and you will perform like that. That is, if you have to do it for the interior wall, then the light cable will go down with the resectoscope, but CCD of the camera should be in the same position. CCD should not be changed. How to do? Tomorrow we will do the practical in the lab, and then you will do yourself. So this is how interior wall of the uterine cavity is resected. Sometimes some bubbles are getting deposited there. Those are hydrogen and oxygen that disintegrates into the water, and gas is getting deposited there. So this way you can perform, and slowly you can do the resection. Now how you will know that it is finished? That you have to see the texture of the surrounding. If the brightness of this area is equal to the brightness of the surrounding area, that means you have reached to the maximum limit, and then you should not go further. So right now this is brighter, this is darker, so you can go. But once the brightness will reach to the equal, you will stop. Sometimes you have a very big myoma, and then it will not allow you to introduce your hysteroscope. So for fraction of minutes you might have to increase your pressure for a long time, and then you will see here, this is myoma. Now you can go with the resectoscope, and you can cut 2-3 big chips out. First you cut few chips out, and then you will have now the space, working space, and then the rest of the tissue can be taken. So this is for the huge size of myoma, which is almost occupying the entire uterine cavity. You cannot use at 180. You may have to increase for few minutes up to 300 or 400 millimeter of mercury, but extreme care that as soon as your space returns to the working space, you should decrease the pressure. You should decrease it to 180, and then you can take the big chips out. Here you can see these big chunks, 2-3 chunks were taken out, and then it will be easy. This is the big piece out, and then it will be easy now to perform rest of the part of the myoma, and that way you can do it. So submucous myomectomy is a good procedure, and it can be performed in any wall, interior wall, posterior wall, and now you have good cavity to take rest of the myoma out, and then resection can be performed. Sometime you have it on the interior wall. Now again you can go and always come towards you. Don't go away from you. You go and come towards you, and here it is cutting with the electrode. Again you go, again cuts. Again you go, again cut. Again you go, again cut. And then you will see the darker. Darker means deeper. Brighter means nearer. So you must see that if this is darker and this is brighter. So that way texture gradient helps. This is a high speed. During the video editing, the speed was increased, but actually you will never do that much speed. You have to do slowly this procedure, and then it is not necessary to take 110% all the tissue out. Even near 90% you will approach, then the rest of the part will degenerate, and it will be expelled into after degeneration out. And here we can see it is cutting again. So slowly you can cut all the myoma, and you can remove it. Sometimes you may need the Medex pump. Again this is posterior wall, and this is loop electrode. You will go and you can resect it. This is brighter, that means it is elevated, and here this is dark, that means it is deeper, and slowly you can cut it. Again you go away and come towards you, and here it is cutting. it is cutting. Again you go, come towards you, it is cutting. That way you can separate all the myoma. It is a very good surgery for the infertile women, because submucous myoma is really a cause of infertility in many situations, and the abortion, frequent abortion can happen. In those situations it is rewarding procedure, and it is again, this is slowly a small chips will come out and you can cut all the myomas. So this is how the laparoscopic myomectomy is done for the posterior wall. And when you are seeing that the texture of the surrounding is coming nearer to the surface where you cut, then you have to be dead slow. That means now you are approaching the surface, real surface of the uterus, and now can you see now? This texture and this texture is equal. Texture, brightness of hair and brightness of this is equal. That means now it is over. And that is very useful trick to find out the surrounding. Like see here, this is little dark and this is bright, so this area can be cut. Here there was one small polyp also, a small myoma also, pedunculated, and that myoma pedunculated you can remove in one go. How? We will see that. This is cut here, and then you will see that one small myoma was there. That is just 1 or 2 centimeters small, 1 centimeter maximum. This myoma is already cut, and here this one. Can you see this? This is. Is it visible? This is here, but it has a small pedicle. So this is a work of one shot only. You go beyond that, and here it is. Now just cut in one go. That's all. So very small myomas are very easy, and especially if it is pedunculated and grade 0. Sometimes you are using the good quality energy sources. Do you know there are many type of, this is plasma sect and this is plasma V sample. These are bipolar technology actually. So you have to use normal saline. Here you cannot use glycine. Ethicon, Johnson & Johnson is selling this product by the name of VersaPoint. And VersaPoint is a bipolar technology. If you see very carefully, it is just like a twin blade. If you see that it has a, this is plasma sect, and it cuts very smoothly with the bipolar technology. And this is plasma V sample, and it doesn't need glycine. If you will put the glycine, it doesn't work, because normal saline is required as a medium to pass the electron from one electrode to another. So this is bipolar technology which you can use. Here we can see this is just like, I don't know, this video has some hitch. It is little bit inhibiting to work, but you will see that there is a spark between the two blades. I will show you. This is one electrode, this is another electrode. And can you see some spark? See the spark in between two blades. Can you see there? Here, this is a spark. And it is such a high frequency that it is evaporize the tissue. So one drawback is sometimes you don't have much tissue for the histopathology, and in those situations you have to be careful. So these type of high-end energy sources are also now available for hysteroscopy, which you can buy. Cost of VersaPoint is little expensive. It is 15 lakh rupees for generator, and you have to use their own generator. But these will make your surgery much effective, and the chances of complication also can be minimized. There is no problem of the hyponatremia. Sometime you have a septate uterus. In those situations you will do the probing, and then you will see the whitish band there in the middle. White band like a structure will be visible, and then you can do the metroplasty. This is just, you have to split it in the middle. This is brighter, means nearer. This is darker, both the side you can see dark. That means still we have to go. It is long way, and slowly you will keep on cutting in the middle. As soon as you will start approaching to the base, towards the fundus, the thickness of the septa will increase, because septas are like that. Towards the cervix it is thin, towards the fundus it becomes thicker. And laparoscopically how you are confirmed that there was a whitish band in the middle of the uterus, and now it is splitting, and now you can see brightness of the surrounding is coming nearer to the tissue. That means it is now approaching, and that means you have to be slow. So that way it is easy for the texture gradient to help you while you are doing the operative hysteroscopy. And now it is over, because it is now equal to the other, and it is done. Sometime what happened, that you have the, here this is a uterus, and there again you have the whitish band in the middle. This is laparoscopic view. That was very good septate diagnosis. This is the band, and this was pathognomic flattened uterus, anteroposterior. This is fallopian tube. This is triangle of Doom. This is uterosacral ligament. Now this is hysteroscopy. This was little delayed. Ideally hysteroscopy should be done post-menstrual, but here it was little proliferative phase. So that's why you can see the good proliferation of the endometrium was visible. Now this is septa. This compartment is a small, one compartment was big, and then you can use Collins knife, and with the help of Collins knife you can start cutting in the middle, and slowly you will approach towards the cervix. You can see it is so thin that it can get the entire Collins knife can approach it. It was too thin there, and but once you will go towards the fundus, the thickness increases, and here it will cut. Slowly you will use cutting current, yellow paddle, cutting current, and your generator must be 400 watt. You cannot use conventional 250 watt generator for hysteroscopy, because it is an underwater cutting and coagulation. So 400 watt generator is required, and then it is cutting. You can see it is just thin, and even it is thinner than the Collins knife tip, but once, and it is brighter, surrounding is dark, that means it is good. You are secured, and you can go easily, and you can keep on cutting. But once you will approach towards the fundus, thickness will start becoming increasing. Then you have to cut in a step ladder fashion, 1, 2, 3, like in the steps. You should not try in the hurry to get it, and a step ladder. And sometime if the laparoscope is from above, it gives you the trans illumination, and with this trans illumination we can visualize it better. That will have the additional advantage. So laparoscopes, many of the gynecologists during any operative procedure, they keep one laparoscope from above, so that they are sure about the trans illumination, and that light helps. Now you can see the septa is much thicker, and then it has to be taken in the step ladder, step fashion, and then in the middle only it will be a split. Due to the pressure of the fluid, automatically it will go away from each other. This is trans illumination. Can you see the light? This is the light coming from the top. This is the laparoscopic light, and this is this video has this problem, that whenever this is the light, whenever I ever start, it goes again to the, there is some hitch there, I don't know what is there, but thanks God it started again. So this way, here there is no light, this is okay, this part is not completely finished, and again you can cut it. So slowly you can cut in both the area, and you can reach towards the fundus, and once you are going nearer, you have to be slow for prevent the perforation, but still little dark, so you can go. And this way septate uterus, unfortunately we cannot come towards us from away, that we cannot do. We have to go away from this. Now see, brightness of both is equal almost, and then it is the point where you have to stop. Here this is the point to stop. Sometime again you can call for trans illumination, and your assistant who is putting the telescope from above, he will bring the laparoscope almost touching the uterus, and that way trans illumination can give you the idea that it is finished or not. This way it can be performed with the metroplasty. And sometime if you are going to check your this tube for the patency, that also you can do together. So this is now cutting here, and it is separated. This way you can cut the septa in the different layers. So again this is left side little bit, this is dark, this is bright, so still you can go ahead. So this area is now cutting. So this way metroplasty is relatively easy surgery, especially if it is a small septa and you can cut it. Now, sometime you have to do hysteroscopic sterilization. That you can do with the SCO2. SCO2 is a implant which is made up of dacron and nitinol, and that you can introduce. They are giving you a guide wire loaded, so you don't have problem. Just you go, this is cervix, this is cervix, this is cervix, this is cervix, and this is now in the uterine cavity. Once you will enter to the uterine cavity, then you will look for the ostia either side. This is the ostia here, this is the right ostia, and here is the left one. This is left ostia, this is ostia, and now this is the guide wire, and the SCO2 is loaded on the guide wire. It has two parts. The dacron part has to be introduced into the tube, and the nitinol part is a metal part that will keep on dwelling into the uterine cavity. And advantage is that you can get the X-ray done to check it that it is in the position. This is going now the nitinol part. Nitinol part is just like a coil, just like a refill ball spring of the ball pen, and this is the nitinol part. And now you will pull the guide wire out, and this is guide wire out, and this is the dacron nitinol part of the SCO2 is in this one. This is the nitinol part. Nitinol is a inert metal. It doesn't react with the human body. It is used by cardiac surgeon, and it is used in the staplers also. The tackers and the clips are made up of titanium, but the staplers are made up of nitinol. So again, this is the other ostia, and this is the dacron portion of which you can push into the ostia, and nitinol portion will be inside the uterine cavity. And that way hysteroscopic sterilization. What is the drawback? That it is absolutely irreversible procedure. It cannot be reversed because it will fibrose the entire proximal end of the tube. Even recanalization you cannot do. And some people they cannot tolerate because they have some. This is the nitinol part which is dwelling. And some people they don't like because sometimes it is reported that they are having the low back pain and all, and it is a little expensive rather than the other. But it is an office procedure, outdoor procedure, and in multipara within 10 minutes you can introduce the SCO2. Patient must be avoid intercourse at least for 1 month, 4 to 6 weeks, because it is sometime creating inflammatory reaction also. That's why it has to be kept in mind that sometime patient may get pregnant if the tube has not yet fully fibrosed, then she may get pregnant. So that should be avoided. Now complications are that the trauma, cervical laceration, uterine perforation, injury to the intra-abdominal viscera, rectum, bladder and intestine. This is one of the very common complication of the injury. That one injury already you have seen during your course, isn't it? That it happens. But luckily it was only the uterus, not the rectum or not the bladder or not the intestine. So, and there was already a perforation pre-existing. Now intravasation. Intravasation means the fluid will enter into the blood vessels, and that could create you different type of water intoxication, hypertension, fluid overload, or sometime hyponatremia. If the patient has these diseases, suppose your patient is already suffering from the uterine tuberculosis, submucous tumor, hyperplastic uterus, recently traumatized uterine cavity, proximal tubal obstruction and excessive pressure of installation, means if it is already hyperemic uterus due to TB, due to cancer, due to some injury, due to inflammation, due to infection, that means it is hyperemic. In hyperemic uterus, chances of intravasation is manifold increases, because it can take the fluid very fast, and then you have to be more careful about the timing of the procedure. You should not go for a long time. Now other complication is infection. There may be salpingitis can increase, PID will be big problem, and febrile reaction. Sometimes patient will get severe fever, bleeding can happen, mortality also is possible. Now my question is, there are two regions of the immediate mortality. What are those? Very good. One is embolism, another is vasovagal shock. If the patient is making immediate death, then these two problems has to be kept in mind. that embolism should not occur and vasovagal shock should not occur. So excessive pressure of installation can trigger both these effects. If you have a lot of pressure, then any air can enter inside, or sometimes even the fluid rod can create the air embolism. So this has to be kept in mind. Very high installation pressure and very high flow rate should be avoided during the hysteroscopy, otherwise there may be problem. And other cause of mortality is delayed mortality. Delayed mortality is generally due to peritonitis. Suppose you will do and it is perforated, and then you perforate and you pull some portion of intestine also out with the loop electrode, and you never know also, and suppose intestine, then peritonitis will happen, and if it is not properly tackled, then septicemia and patient may die. So these are the causes of mortality during hysteroscopy. One is immediate, another is delayed. Now contraindication, absolute contraindication is adnexal and endometrial infection. Once you enter inside and you saw a very bad infection inside, don't do hysteroscopy. Leave the patient for some time for the antibiotics, and you can give some anaerobic also, metronidazole and all, and some antifungal pessaries and all, then call the patient and do it. Otherwise you are going to push all the infection through the fimbrial end into the abdominal cavity, and if you have not combined it with the laparoscopy, you cannot be able to clean it, and then can exacerbate the PID, and there may be peritonitis. So in infective state it should better to be avoided. Another relative contraindication, in menstruation you should not do. Why in menstruation hysteroscopy should not be done? Pardon? Endometriosis. One will be endometriosis. All the sedated endometrium can go. Another problem is there is more chances of intravasation. Another problem is, he is correct, there is very bad vision. Because of blood it will absorb all the light and you cannot see anything. So this is a contraindication, but relative, because sometime in emergency suppose you have to do it. Another is pregnancy. Why in pregnancy it may be necessary any time? Hysteroscopy is contraindicated in pregnancy, but it is not an absolute contraindication. Why? Because ectopic pregnancy of the interstitial pregnancy is one indication, hysteroscopic removal. Another is that sometime if you have a copper T together with the baby, then some female does not feel comfortable. They say you to remove it. I am ready if the abortion happens. Although in the book it is written it is not necessary, because baby will come with the copper T in the hand. So you may not need to remove the copper T there. But why to remove it? Because of psychologically sometimes they don't tolerate it. And 50% of the cases, if you do hysteroscopy carefully, without abortion you can take the copper T out, especially in the early stage, and it is possible. So this is indication. Another indication, sometime heredity for mole, partial pregnancy, molar pregnancy, that is one hysteroscopy is one indication. So but it is nowadays rarely used. Why? Because we have very good quality 4D ultrasound, this, that, and that can evaluate. MRI also is a good investigation for pregnant patient, and that can create safely than these procedures. Now cone biopsy of cervix and pelvic irradiation, if it is done, don't do it. If pelvic irradiation is taken, then there is a chances of a lot of weakness of the wall due to fibrosis, and there may be chances of perforation. Then if the cardiac or pulmonary disease patient has already, then little bit sodium potassium he cannot tolerate. So if the patient has a cardiac and pulmonary disease, we will not do it. Then recently a scarred uterus and adhesion. The patient already has recently a scarred uterus and adhesions, in those situations also hysteroscopy should be avoided. Why? Suppose someone has done MTP and that patient came to you, and then you will think that I should do hysteroscopy, and it will perforate, then all the fluid will enter into the abdominal cavity and there may be peritonitis. So at least 6 week time we should give in interval in between the two procedures. Like immediate cesarean section has been performed and that patient comes to you, don't do hysteroscopy, because it is a recently traumatized uterine cavity and that uterine wall is weak. So these are some of the relative contraindication which we have to keep in mind. So is there